Well, thank you for joining our special June webinar, an additional webinar that we wanted to bring to close out this month and focus on what to do after screening and how to get the support that you need to transform dementia care in your practice. Before we get started, I wanted to just summarize some of our program offerings. Many of you might be familiar with some of these, as you might have participated in some of these events or trainings in the past. But we do have a lot of things to offer interested individuals around dementia care. We have a warm line, which we launched a few months ago, which is a wonderful resource for providers. It provides consultation support and connects primary care teams with dementia care experts. We also have online trainings, mainly our cognitive health assessment training. And we have monthly webinars, this is one of the webinars or one of the additional webinars, but we have other webinars on kind of more focused topics related more directly to the cognitive health assessment. And we also have a podcast, Dementia Care on Air, if you want to take a listen. We also have interactive case conferences, echoes, and we also provide practice change support through the UCLA Alzheimer's and Dementia Care program, as well as Alzheimer's Association. And both of those programs are here today to speak with you about all they have to offer and all the support they have to give. And to just focus back on our training, which is our cornerstone offering for everybody, we have, you can find it on our website, dementiacareaware.org. We have an online self-paced training that you can take at your leisure to start and finish whenever you'd like. But we also have live training opportunities, and the next one up, I believe, unless the Alzheimer's Association has one before, but the next one up on my calendar is on July 11th. And I'll put kind of the link in the chat to our cognitive health assessment training site in just a moment. But we do host live trainings, which is an hour long. I know UC Irvine hosts them every first and third Friday. And I think the Alzheimer's Association also has opportunities at least once a month. I don't know, Ondine or Cheryl, if you have information on that you want to drop in the chat. Okay. So, oh yes, and the screening for the cognitive health assessment really is just meant to be an annual screen for patients over 65, where you take patient history and use screening tools and document, you take patient history and then use screening tools for cognition and function, and then document their information in the EHR. So all of this is to hopefully allow providers to start a brain health plan as early as possible. All right, so we have some amazing speakers today. From the ADC program, UCLA Health, we have Michelle Panlilio and Dr. David Lee. And from the Alzheimer's Association, we have Cheryl Brunk and Ondine Bolter. If I butchered your last name, I'm sorry, I forgot to ask for pronunciation for that one. I've never said it out loud. But we have amazing speakers today. And we will also say that none of them have financial disclosures to disclose for this presentation. We have some learning objectives that we just want to cover. This will be important for those of you who are looking to claim CE credits. But essentially, we want to make sure that you're able to describe the benefits of these programs and identify some next steps that really can help you enhance dementia care in a clinical setting. So without further ado, I will pass it along to the Alzheimer's Association to start their presentation.
Thank you so much, Danielle, and thank you to all of you who in the audience who are taking your time to hear more about how we can support you, health systems and clinicians, around the topic of Alzheimer's and dementia. Next slide, please. So, while the overall discussion today revolves around building better outcomes and responding to the needs of our communities, we'd also like to share components of the Alzheimer's Association. You may not know that the Alzheimer's Association is the world's largest private nonprofit funder of Alzheimer's science. We're also a global leader in Alzheimer's care, support, research, and education. And you'll hear more today about how we provide clinical consulting and practice transformation support across all 50 states, actually. As a mission-driven organization, the Alzheimer's Association has shifted its focus over the past several years from a social service to a public health model, so driving risk reduction, early detection, and maximizing quality care and support. With this investment, our goal is to achieve the quadruple aim of improving the healthcare experience for all while lowering costs and improving population health. Now you see this slide represented here. We're still in the month of June, and it's Alzheimer's Brain and Awareness Month, which is a global event observed for the entire month of June, and it commemorates the awareness of Alzheimer's and other brain diseases. This month highlights the importance of early detection, early diagnosis, and its impact on the families of people affected. So simply by attending today's webinar, you're a part of the movement and learning more about this disease and how we can help. We also know that worldwide, there are more than 55 million people living with Alzheimer's disease or another dementia. So the more that people know about Alzheimer's, the more action that we can inspire. So I appreciate that, and thank you for being here. I'd like to just touch upon the growing evidence. We'll go back to the other slide. I'd like to touch upon the growing evidence that indicates people can reduce their risk of cognitive decline by adopting key lifestyle habits. And so when possible, combining these habits to achieve maximum benefit for the brain and body. It's never too late and never too early to incorporate healthy habits. So our work right now with the Healthy Brain Initiative Roadmap is really a framework for designed to provide public health officials throughout the nation with a set of strategies to promote brain health and improve the quality of life for people living with dementia and their caregivers. So we know that the annual cost of California's Medi-Cal program is in the billions. Almost 2/3 of Americans with Alzheimer's are women. And while older Black Americans are twice as likely to have Alzheimer's or other dementias, older Hispanics are about one and a half times as likely to develop Alzheimer's and dementia. So the following conversation and slides will showcase what's next and how we can continue to partner. Here we are, next slide. Okay. Actually, it's the other slide. So in 2019, the Alzheimer's Association launched a new health systems initiative. And the goals of the initiative are twofold. The Alzheimer's Association is partnering with medical experts to address the rising costs of dementia and improve patient experience and outcomes along the way. So we know that the lion's share of primary care physicians feel it's really important to assess for cognitive impairment. And most seniors believe that it's important to have their memory checked. But we also know that only about half of seniors are being assessed for cognition. So more than half of physicians share with me and Ondine as our work progresses that time is really a primary reason for not being able to assess older patients for cognitive impairment. And I get it. I mean, sometimes we have 15 minutes with a patient. So, but we also know that 9 out of 10 primary care physicians do want further guidance on the cognitive assessment process. And this guidance includes which assessment tools to use, how to use them, which patients to assess, and what to do when an assessment indicates a positive cognitive impairment. So we applaud you for leading the way by taking the cognitive health assessment training with Dementia Care Aware. We are going to discuss how the Alzheimer's Association can support you in transforming your dementia care practices. And just as the prevalence of Alzheimer's disease increases, so does our need for additional members of the workforce who are involved in diagnosing, training, and caring for those living with the disease. So I'd like to turn it over now to my colleague Ondine, and she can share more.
Thank you, Cheryl. We're going to move to the next slide. As Cheryl mentioned, we know that the prevalence of Alzheimer's and dementia is increasing, and we are here to support and enhance the critical work of clinicians and health systems in identifying and caring for those living with Alzheimer's and all other dementia. We don't just support those living with Alzheimer's, we really look at all types of dementia, including Lewy body dementia, frontotemporal dementia. So we want to be inclusive of that community. We do this by utilizing many different approaches, and it really starts by connecting with us, a member of our health systems team. And in California, we are lucky enough to have 4 health systems directors, Cheryl and I, supporting the northern part of the state, and 2 more in the southern part of California. We meet with you and members of your clinical team at no cost to assess your dementia readiness and work with you to explore and identify opportunities to enhance care and support for your patients and for their families. We continue to work as partners with you in this journey through implementation and evaluation and ongoing process improvement. We have practice support offerings suitable for really all health systems clinics, covering a variety of care settings from hospitals, emergency departments, ambulatory clinics, and private practice. Now I'd like to share a little bit more about some of the ways we can support you in enhancing and implementing those strategies and solutions to ensure early detection and quality care for people living with dementia. Next slide, please. The Alzheimer's Association provides a variety of no-cost resources for health professionals to help enhance care and improve outcomes. Many of them are available to you right now on our website, alz.org. As you may be aware, we provide many on-demand, self-paced learning opportunities, inclusive of continuing education, in addition to our live training opportunities, some of them, as Danielle mentioned earlier. Our Dementia Care Aware series is ongoing. We provide 2 trainings per month in the cognitive health assessment, as well as our Alzheimer's and Dementia Care ECHO program, which offers primary care professionals no-cost advanced training and support through 12 bi-weekly case-based interactive video conference sessions. ECHO stands for Extension for Community Healthcare Outcomes, and it provides an opportunity to build your expertise and become a leader in dementia care. In California, our ECHO series is conducted in partnership with both UCSF and UCLA. It's a free telementoring program that combines brief expert presentations with interactive and practical case presentations directly from the participants to build dementia care expertise. Coming right up is our Alzheimer's Association International Conference on July 16th. It's being held this year in Amsterdam and online. It is the largest and most influential international conference on dementia science, where you can join distinguished scientists, clinical researchers, and early career investigators and clinicians in the research and care community. Please visit aaic.alz.org for more information, and we can put that in the chat as well. For all of our continuing education opportunities, I'm going to point back to that great website I mentioned earlier. By the end of this presentation, you can probably tell me what that is, alz.org. So please go ahead and visit there at any time, where you can find a library of our free toolkits and clinical topic sheets, including resources for conducting cognitive assessments, toolkits on care planning and Medicare reimbursement, topic sheets available in English and Spanish on subjects such as managing difficult behaviors, caregiving, and legal and financial considerations. We also offer guidance for medical management and patient care, including diagnostic criteria, information for recruiting for clinical trials, as well as our new AlzNet. It's our Alzheimer's Association Network for Treatment and Diagnostics, which is a resource to collect and use real-world data to improve brain health outcomes and manage treatment. So again, I'd like to point you to our website. I think Cheryl will put it in the chat. And moving on to our next slide, I'd love to talk more about our in-depth practice support, consultation, and quality improvement services. Through our health systems practice support, we consult with clinics and systems to determine really what approaches and tools are most appropriate. We support we support our practices in transforming their dementia care by offering many tools to support you in this journey of system change, practice change, and quality improvement. We partner with the Institute for Healthcare Improvement in supporting clinics and systems in becoming age-friendly. We also work with the American College of Emergency Physicians to support hospitals with geriatric emergency department accreditation. We consult in the implementation of culturally competent cognitive screening tools, EHR and workflow enhancements, as well as work with you to build a dementia care pathway. We also work closely with our partners at UCSF to support implementation of their dementia care model, the care ecosystem, as well as our friends at UCLA in their ADC model, which you'll hear more about in a few moments. So now I'm just going to get into a couple case examples, the first of which is local to me in my Bay Area home. If we could move to the next slide. Thank you. One more. This is just an example of a system we're currently working with in the Bay Area. And as you can see, I've taken sort of a timeline approach. This is an ongoing partnership, and it started a couple of years ago with some clinicians in the system who participated in our Project Echo series. This system sees about 65,000 patients. They're an FQHC with multiple clinic locations throughout the Bay Area. 15% of their patient population are over the age of 65. So we are working with them after they've continued their education with Project Echo. We are working with them to really make their cognitive screening a consistent practice. So they re-engaged with us this year in doing more DCA training, our Dementia Care Aware training on the cognitive health assessment, so that all of their primary care physicians had that baseline level of training in the mini-cog. And we then identified some of the strengths and gaps in care and have been implementing an ongoing QI project to take that mini-cog and build it into their workflow for all patients over the age of 65. In addition, we're providing ongoing clinical education across all of their clinic sites. And really the hope is that in the future, hopefully 2024, this system will be working toward their age-friendly, committed to care excellence designation, as well as integration of new workflows and care pathways in their EHR. So I'm excited to see what's ahead for this clinic, and Cheryl's gonna jump back in to share about a clinical site she's working with, just to give you another example of a system that we work with in a different part of the state. Thank you.
Awesome, thank you. Well, this is a health system that we're working with in the Central Valley of California. And really it started as an opportunity to partner years ago in support of caregivers throughout the Central Valley and what to do. And we took the opportunity to enhance the clinical education practices within their organization. And so they too have been participants in the past and currently with the Project Echo campaign that's going on in the North. We took the opportunity with 2 existing clinics to identify, gee, how is it going with the cognitive screening? And we established a quality improvement project to identify an increase in the number of screenings that they could do with 65+ patients, and whether that was through the annual wellness visit or any visit that the patients were coming to. And then the other clinic, we took the opportunity to establish a dementia care pathway for, what happens after the screening is done and there's challenges and we need to get them to treatment, and who do they go to and what happens within our own organization. So we're in the midst of those 2 projects right now, but we have nice plans for the future. And this particular health system, we worked with the family medicine residency program because it was an opportunity for them to gain skills with different quality improvement or practice change projects within. And we have a bright future for the work that we're doing. But this is, a small lift, something you can do within that. You certainly had the opportunity to have the training, and now what, right? And so this is an option for all of you as we move forward. I'm going to go to the next slide. And really, we're kind of in the home stretch for our part of the presentation, but I wanted to make sure, as a few of you may be looking like, well, what could I walk away with today? And, make sure that you have awareness of the Alzheimer's Association's 1-800 helpline. It's a 24/7 helpline in multiple languages, and it's probably one of our most utilized services for people who are on their own or needing support, but clinicians use our 800 number as well. Certainly, we have no-cost family care consultations that are provided through the Alzheimer's Association. And then on an ongoing basis, we have education programs that are offered not only in English and Spanish, but also Chinese. And so that's, you can see on the right side of the screen, the different educational classes that are on a rotating basis. And then, certainly for those with early stage interventions, we do have support groups, and then also for our caregivers as well. And that's up and down the whole state of California and nationwide, but we're hopefully talking to our California audience today. And then finally, our trial match, which really connects individuals living with dementia and their caregivers, healthy volunteers, to clinical trials that may help advance Alzheimer's research. This is a free, easy to use service that allows you to see which studies might be a good fit for you. And in my case, I am a healthy volunteer in the study, and it's really fascinating to see how your own life can make a difference in this. So that fairly well concludes, Danielle, if you can fast forward to the next slide. That concludes our part of the webinar today, but I want to just thank you all for your time and attention to this very important topic. And we look forward to partnering with you now and also in the future. So thank you so much.
Thank you, Alzheimer's Association. And I did put some links in the chat, and we'll go ahead and share some additional ones. And if you have any questions or comments or anything you want to share, the Q&A should be available for folks to add their questions and comments. So now I'll pass it over to UCLA Health.
Great. Thank you so much for having us. Just a little introduction. So my name is David Lee, and I'm a geriatrician here at UCLA. I'm also part of the PhD program looking at organizational behavior and implementation science. I feel very fortunate to be able to work with Michelle Panlilio with the ADC program, with Jagrup Kaur and Dr. Dave Rubin and a number of other people to help implement the UCLA practice support. Next slide. So today for our component, what we'll talk about is basically the components of dementia care management. So after someone's diagnosed with dementia, thinking about strategies. Then I'll go ahead and talk about practice support through different models of comprehensive dementia care and looking at differences there. Then Michelle will go ahead and start talking about the Alzheimer's Dementia Care Program and some additional trainings that are being offered through UCLA. So just to kick off, after someone gets diagnosed with dementia, there are a number of strategies people may want to utilize. The first is knowing that Alzheimer's disease and related dementias, they're a lifelong disease. We unfortunately don't have a cure, even with some of the anti-amyloid medications that are being pushed out. They don't reverse the disease. They don't completely get rid of the disease. So knowing that it's a lifelong disease at the moment. So with that knowledge, we play the ball where it lies. Essentially, if the disease is early on, we include the person living with dementia in disease management and decision-making. When the disease progresses, we rely more on family members and caregivers to really help with some of the disease management. The next thing is we really want to aim for the highest level of independence for that person, meaning if we can have them stay at home and age at home, if that's the most safe and comfortable environment for them, we try our best to be able to allow that to happen. We treat the disease, meaning with the stuff that we have, including cholinesterase inhibitors, memantine, and those types of therapeutics. We want to manage hot button issues such as driving. We want to manage other comorbid diseases, including COPD, diabetes, heart failure. We want to make sure all of those things are taken care of as well. We want to manage symptoms. Those can include neuropsychiatric behavioral symptoms, but also recurrent UTIs, recurrent pneumonias, and things like that. And when we do have the opportunity with the patient, with their caregivers and family members, we really want to make sure that the advanced care planning is taken care of, because eventually when they're no longer able to make their own decisions, having the advanced care planning already in place makes things a lot better. And the last part here is caregiving support, which is an instrumental part in caring for someone with dementia. Next slide. And it's so important, we wanted to have a whole entire slide on caregiving support. Caregivers are incredibly important in managing symptoms for patients with dementia. And they're more important than even, I would say, geriatricians or other primary care physicians, actually. They're the ones who are working with the person living with dementia. And so it's part of our responsibility to also take care of those caregivers as well, with over 50% of caregivers actually developing depression and other conditions due to their role. What studies have found is that when caregivers are more knowledgeable and empowered to provide caregiving, they actually provide better care. And so as a result of that, there are a number of support programs out there that are targeted specifically for caregivers. And I've listed a couple of programs and even some resource here, with Reach 2 being one of them, and the NYU caregiver intervention being another. There's also a number of resources from the Alzheimer's Association and other community resources, and you've heard some of them just before this talk. Next slide. Now, when we talk about comprehensive dementia care, we really have to focus not just on the person and the patient, but also on the caregiver. So we think of comprehensive dementia care as including both individuals. And there are many components of comprehensive dementia care. Some of them including a continuous monitoring and assessment of symptoms, ongoing care plans, and adjusting those care plans as needed for the particular individual, psychosocial interventions that are aimed at the person living with dementia, aimed at their caregivers, making sure that their needs are met. We also want to provide education for caregivers, family members, for patients regarding self-management strategies and tools. A lot of comprehensive dementia care programs also include medication management, mainly focusing on dementia care. However, some programs also focus on comorbid conditions as well. And that gets into the next part of treatment of related conditions. And lastly, providing care coordination, being able to help navigate the complex healthcare system and making sure that they receive the resources that they need. Next slide. So understanding comprehensive dementia care, what do we do about that essentially? Now, what models are available to us? Next slide. Currently, there are 6 major models of comprehensive dementia care that are being utilized and disseminated throughout the country. And they all focus on patients and caregivers. And we've listed out the 6 here. So the first one listed out is the BRI care consultative model. And essentially it's provided through phone and emails, through non-licensed staff with the support of social workers, with nurses and additional support staff. You have the Mind at Home program as well, which is actually in person at home, and they're staffed by non-licensed providers, and they are supported also by nurses and geriatric psychiatrists. And then you have the care ecosystem, which you heard about a little bit from the Alzheimer's Association, also provided a lot of times virtually. The Indiana University Health Aging Brain Center provides in-person visits and it's usually staffed by the nursing nurses, social workers. They have psychologists and physicians as well. You'll hear a little bit more about the UCLA Alzheimer's Dementia Care Program from Michelle, but this is also staffed by nurse practitioners, PAs, and they provide co-management with the primary care providers through in-person visits. And lastly, we have the Integrated Memory Care Program, which is provided, which is supported by advanced care practitioners, and they actually provide the primary care for persons living with dementia. And we have these 6 models described here, and we want to talk about how they differ a little bit. Next slide. And so these comprehensive models differ in a number of ways. So we talked a little bit about their staffing. What we mean by base of operations is whether they're embedded within health systems, whether they're embedded within community-based organizations, their scope of services that they provide, some providing 24/7 support in the form of telephone or other types of services, others actually only operating during business hours, the intensity of support, the cost in order to implement and to sustain some of these models, the efficacy and the effectiveness, and how pragmatic some of these models are specifically for your system, potential return on investment, and the level of evidence, with some of the models actually being part of randomized control trials. There are a number of them have either retrospective analysis or quasi-experimental study designs to study their evidence. But overall, understanding that a lot of these comprehensive care models differ and they may fit your organization in different ways, and understanding which model may be a better fit for your organizations over another. Next slide. So this slide is a little bit busy. It includes a pretty extensive table that compares all 6 models and looks at how they differ in a number of different ways and different features. Now, this is just a part of the ways that we've compared all 6 models. We have a little bit more of an extensive model. And when we work with organizations, we essentially ask specific questions about your organizations, about the goals of your organizations, and really try to find a model that may align with your organizational features, your characteristics, and what the goals of your organization are, in order to make sure we match a model up with what could work for your organization. So I won't go in depth about this slide, but more than happy to share this this document and kind of the other features that we've looked into. So then I'll hand over the next portion to Michelle.
Thanks, Dr. Lee. Hi, everyone. My name is Michelle Pandolio. I'm a geriatric nurse practitioner by training. I have a couple of different roles in the program, and so I'll talk about the 2 main roles that I have for UCLA ADC program. Next slide, please. So the first hat that I wear, and this is what I'll talk about, is I'm a dementia care specialist for the ADC program locally. And that program is a co-management model of care that takes care of patients and caregivers who are living with dementia. And so, excuse me, the ADC program's mission is to partner with families, physicians, and community organizations, really to maximize a patient's ability to function and while minimizing caregiver strain and burnout. Next slide, please. So the program, we are housed in the Department of Geriatrics, and as clinicians, we recognize that the dementia journey can be a long one, both for the patient but also the caregiver. Excuse me one sec. Excuse me. And the approach is that, again, we take care of the patient and the caregiver, and we call them dyads. Now, the co-managed model, as Dr. Lee had been talking about, it's a co-management where the primary care physician partners with the nurse practitioner or dementia care specialist in this case. However, they continue to provide primary care for the patient and will manage the patient's dementia care. Excuse me 1 second, I just need to cough. Sorry about that, everybody. Okay, so as I was saying, so for our patients, although we provide terrific care at UCLA, we are limited in our scope of service. And so we reach out and we have actually partnered with, in Los Angeles, we have 8 community health organizations that we work with so that we are able to support the care of the patient and the caregiver when they are living outside in the community. Next slide, please. Okay, so when patients are, once they have established care with the UCLA program, then they really do have access to a clinician 24 hours a day, 365 days a year. We see them in person for annual assessments, but really depending on how busy or how acute their needs are, then we see them at minimum, again, once a year, but sometimes as often as once every month. Excuse me 1 second. I apologize, everyone. I think I'm having an allergy attack. But moving forward, we do have, for each patient and caregiver, they do get individualized dementia care plans every time we see them. Next slide, please. For partnering, CBO stands for community-based organizations. Now, these are services that we refer our patients to, again, whether it's for services that we are not able to provide, so adult daycare services, for our patients in the early stages, then we have programs for managing their brain health. Now, for the caregivers, and I think, all of my colleagues on this presentation have so far mentioned how important it is to talk about, how well we are providing support for the families as well as caregivers. And so in partnership with our community-based organizations, and this is some of the support that we have for our families and caregivers. Next slide, please. So how are we doing? I think, based on the slide, we are doing pretty well. These are surveys that we have done from all of our referring physicians who have referred their patients over to the program. And for the most part, I think 100% of our referring physicians would recommend the program to other ADC patients, to other patients with dementia, excuse me. Next slide, please. So what happens to dyads once they are established within the ADC program? So on this slide, you'll see some of the findings that we've had from baseline compared to 1 year after being in the ADC program. And, unfortunately for our patients, as expected, they continued to decline cognitively as well as physically. And so, we don't have a cure for the disease. At this time, we're not able to offer that yet. However, they are progressing as expected. What is unexpected, compared to other patients, is that our patients' behavioral symptoms, they improved, they got better. And whether they improved because of the medical recommendations that we made, medical, behavioral, or social recommendations that we provided the patients and the families, their behavioral symptoms got better. And as we know, the behavioral symptoms can be very problematic for a good chunk of our patients. Over 90% of patients experience some form of agitation through the course of the disease. And also, what was unexpected and fantastic is that our caregivers also demonstrated an improvement. So they were less depressed, And really, I think because of the education and the support that we were able to provide, their strain and the distress levels were improved. Next slide, please. Okay, utilization. So again, this is on the same patients that we measured in the previous slide. So what happened? What happened after the patients were in the program for 1 year? We found that because of all the interventions that our clinicians are doing for the dyads, our hospitalizations went down, ED visits, ICU days, hospital days, all went down significantly. And more of the UCLA ADC patients stayed at home, so less placement in the nursing home. Next slide, please. Okay, so the slides that I've covered so far is talking about my one hat as a dementia care specialist. I do have a very divided role, so I still see patients in the clinic twice a week. However, the bigger chunk of my role that I play at UCLA is I'm the national lead dementia care specialist. And so if there are any sites who are interested in implementing the UCLA co-management model of dementia care, then I would be the person that would be teaching that site. And so as far as the ADC program dissemination, this is the actual process that an organization would have to follow if they are interested in doing that. And I just wanted to highlight, this collaboration with Dementia Care Aware. It's just a great example of what can happen when multiple providers who are good and who are smart and who are really driven to make a change. This is what happens. So typically when we have a site who is able to, who's interested in adopting the model, then we would charge them a fee of $50,000. However, through the Dementia Care Aware initiative, we're able to waive that fee for sites who are seeing patients in California who have Medi-Cal patients. Next slide, please. Okay, additional training through UCLA. Next slide, please. Now, we understand that the adoption of the ADC program is really at the highest level of support that we are able to provide at this time. However, it's not always appropriate depending on the resources of the organizations, but as well as the amount of involvement and commitment that a provider wants to participate in. So the Dementia Mini course, it is a great course. It's about 6 hours of commitment and you can take it at your own time. It's all online and you can get CMEs once you have completed the courses. But I feel like this is an example of something that a provider can participate in if they want to get CMEs during their lunchtime and they can pace it at their own time. Next slide, please. National Learning Collaborative, this is a fantastic group of individuals. So we have that. I mean, it's actually getting bigger and bigger, I feel like, every week, because these are all providers, national agencies that have gotten together because they want to improve the care for patients and caregivers who are living with dementia. Next slide, please. The ADC Echo series, and I think this has been mentioned before, as far as UCLA ADC program, we're about midway through with our third session, and I believe we have another Echo session starting sometime in October. And the ADC Echo series, it's a great way to really increase your knowledge, your experience over a period of about 6 months. And Echo series, if you are not familiar with it, you can attend it as a single provider, but you can also invite your team and your colleagues to participate with you. It's a fantastic way to bring up challenging or difficult scenarios, whether it's related to social situations or atypical antipsychotics. It's a great way to bring up challenging situations because the faculty on the Echo series it's a wealth of knowledge. Next slide, please. Oh, I think that's it. If anybody here has any questions about the UCLA model, please contact Jagrup Kaur. She is our fantastic project manager for the ADC program. And thanks so much.
Awesome. Actually, Michelle, I think there's a question for I don't know which slide it came during, but it's in the Q&A. Someone asked, did any of the caregivers drop off? It would probably be, I don't know which slide it was, but did any of the caregivers drop off in your program? How did you maintain caregiver engagement for the span of the program?
Oh yeah. So there are quite a few patients or caregivers who do drop off in the program. Usually somebody else takes over, somebody else in the family takes over. And I think, let me know if I'm answering the question correctly. But usually to be in the ADC program, one of our requirements is for the patient to have a participating caregiver so that we're able to implement whatever recommendations we're making, whether it's medical, social, or behavioral. Did that answer the question?
Yeah. I don't think they can say for sure, but I will also type your answer in for folks as well and put it in the Q&A. Okay, if anyone has any other questions, please feel free to drop them in the chat, and we can open it up that way. But I think other than that, we can conclude our session for today. I want to thank again everyone for joining, and thanks to oh, actually, sorry, another question came up in the chat. The person clarified more along the lines of how many phone calls or reminders or mailings did you send? Are they pretty responsive, or did your team need to be proactive?
Thanks for asking that, and I can definitely clarify that. As far as the caregiver engagement for our program, again, because our interventions are targeted for the patient and also the dyad, the caregivers traditionally they stay very involved. We are fortunate enough to have had Epic, and so Epic healthcare records is a way that they can communicate with us directly, and we open that avenue for them, for them to do that. We also have, because of the co-management model for the dyad, we're able to provide a lot of services just specifically for the caregiver. So things like counseling, educational sessions. We also work with dementia care assistants. So a typical panel for a full-time dementia care specialist and a dementia care assistant is typically anywhere from 250 patients to 300 patients per person per DCS. And that might help you answer, or that might help me explain how we're able to manage the phone calls, the reminders, all the mailings that we do. Margarita, depending on the patient, so we have a system, each patient is assigned to a certain acuity, and depending on that patient's acuity, it really determines how often that patient should be called. So for the medically acute patients who could potentially go into the ER, those patients are usually my responsibility as a clinician. And so, for example, if they have uncontrolled agitation, severe behavioral problems, severe depression, those patients are on my radar. And depending what's going on with them, I might call them at very minimum once a month. However, if it's let's say they're in the ICU or the psych unit, then typically I will talk to those families two to three times a week. And for the patients who are not so urgent, let's say they're pretty stable, they're steady, minimal behavioral problems, then those are actually patients who will be assigned to my assistant, and my assistant will reach out at minimum once every 3 months, even if there is nothing going on, just to touch base. And that's usually a telephone call to the caregiver. What-
And then I do think the next question I probably could be for both speakers, but maybe I'll let the Alzheimer's Association start just because you've done a lot of talking and we'll pass back over to them. But the next question is, what barriers have you faced throughout the implementation process? Have they been unique to each system or relatively generalizable?
That's a really good question. I know with the systems that I'm working with, I think it's trial and error and time. You think you can pull off your data together and get things implemented quickly, and it just takes time. And so, again, staying connected with each other on a regular basis is really important. But I think that's part of our job, is to be that consultant who can help guide them through the process and troubleshoot when things maybe aren't going the way we plan. So, and I'd say that could be a generalization, but it definitely, each health system or medical center has their own unique challenges. And so we try to morph to the needs of that particular clinic or hospital or medical center. So that would be my 2 cents.
UCLA, do you want to chime in?
Yeah, so I can answer that. As far as barriers, I think, the way that I see it, there's actually 2 main ones that I can think of. The first and probably the biggest barrier is not available resources to hire a full-time dementia care specialist, because a full-time dementia care specialist, that is the role for either a nurse practitioner like myself or a physician's assistant. And so, especially after COVID, we've found that although organizations might have a champion who wants to support or implement an ADC program, it's challenging because that role is then being turfed into primary care, or they're being reassigned to, neurology or urgent care instead of what was originally intended for the ADC program. And I think the second barrier for our sites who are not in California is the $50,000 fee to implement the ADC program. Now, again, UCLA is the first one. However, we currently have 16 active sites nationwide who are seeing patients in the ADC program. Now, for those guys who have successfully been able to do so, it's wonderful because they are growing into the role. We are constantly hearing about, their ADC program hiring another provider and hiring more assistants. So because the program is so well loved. And again, that's a reason why I wanted to make sure that, because of the Dementia Care Initiative, everybody is aware that, if you're going to implement and you're wanting to do that, and you're contacting us through Dementia Care Aware, then that $50,000 is waived. So putting that out there.
Thanks for sharing that. Any other questions? Those were great questions from folks. Thank you for speaking up. I tried my best to paraphrase everyone's answers in the chat. Okay, well, if anyone has any last minute questions, you can still ask them. We have 4 more minutes, but I will just circle back around to the beginning. If you haven't taken our training, please visit dementiacareaware.org. I know we also dropped a ton of links in the chat related to upcoming trainings and also resources to access directly on our website. And also yet another plug for our line. If you have any questions that come up in any of your dementia care or in your practice, this line is really just a kind of first line of support. And we can always triage you to the appropriate resources, which might end up being UCLA Health and the Alzheimer's Association, depending on your questions or your needs. So this is really, if you have any questions that you weren't able to ask in this session, or you have some concerns as you start to kind of implement the cognitive health assessment or any other dementia care in your practice, this is really a resource for you, and we're available during business hours, and also have a page on our site that you could submit requests electronically as well. Okay, and so just to wrap this up, we are offering continuing medical education credits for this session. I think Rita just dropped the links in the chat. We have two different links. If you're claiming CME, there's a link for an evaluation survey there. If you're claiming CAMFT, there's a separate evaluation survey for that credit type. And so if you follow those links and fill out the evaluation, there is also a QR code or link at the end of that survey, which takes you to an additional page where you can actually claim the exact credit type. So you follow the evaluation, please give us some feedback and fill that out. And at the end, you'll be directed to actually claiming the credits on our UCSF CE claiming website. We'll also send all this information out via email after the webinar, so be on the lookout for that correspondence as well. Great. And we'll send out, like I said, contact information and all other important links and whatnot after this webinar. Thanks again, everyone, for joining. This was fabulous. And if you know anyone who might be interested in joining a webinar like this in the future, we might hold another session. So be on the lookout for any correspondence about upcoming webinars or events that you might be interested in. Thanks, everyone.